Welcome to episode 229 of the Urology Coding and Reimbursement podcast. I'm your host, Scott Painter, with my co host, Mark Painter, and we want to welcome back Dr. John Lynn, a solo practitioner in Gilbert, Arizona, and Marianne Desciose, COO of PRS Managed Services. As you may have heard from our last podcasts, this is our group that spoke at our Urology Advanced Coding and Reimbursement seminar. And what we wanted to do on today's episode is talk about some of the key points that came out of that and some of the key frustrations that were voiced that we want to share with you that's going on out there in the market today. Welcome, John and Marianne. Thank you for joining the podcast. We love having you on.
Thank you for having me.
Love
All
coming
right.
back.
All right. And then I also wanted to ask John, would you please let everybody know about the Thriving Urology Practice Facebook group that you're a manager of, please?
Sure. The Thriving Urology Practice Facebook group came about because I was frustrated in that there's so much information behind paywalls and there's not a good understanding of how to run a practice better. Not that I know how to run a practice perfectly, but there's just so much information, so much collective information out there that could be shared. So I created this free Facebook group where only US-based urology practices can join. And we talk about stuff like what we're talking about here every single day: how to run your practices better, revenue cycle management, coding, billing, and things about clinical urology.
All right, thank you. One of the conversations that we got doctors excited or frustrated, I can't tell, maybe a little both. Marianne, would you share the information that you shared at the seminar that sparked a lot of conversation?
With PRS, we get communicated with and asked to come in for a lot of old AR projects and review for aged claims that are on accounts. And I was able to take data from the last 18 months that we've been working with many practices, and I took a collection of 134 providers and the basically the adjustments, the collections that we ended up having to consider as a total loss. And this was from claims from 2022 and 2023 dates of service for 134 providers, which equaled collections. This is not charges, of a total loss of over $53 million, to include $21 million of that being in timely filing, over $8 million in authorization errors, medical necessity denials of over $4 million, and then patient collections bad debt adjustments of more than $18 million. And of that, the 38% of that was copays and coinsurance, which equaled a little over $7 million. 36% of that was eligibility errors, and 14% was deductibles, with leaving about 12% in miscellaneous, people who had no insurance. Maybe you had a call where you never got insurance on those patients. But that equaled, over $53 million, which would have been collections payment to each of those providers of a little bit more than $400,000 per provider. So when we are seeing that in the industry on our end, that is just a sample of what we have seen in practices. And in some of those cases, those practices did not survive. So that is what sparked a lot of the conversation and actually frustration, because the providers that were at the conference were actually seeing the same thing within their practices, in the fact that there was not a lot of education or follow-up on some claims, and the process with the insurance companies and the games they're playing and the delays that they have also contributing to that as well.
Hey, Marianne,
Yes.
in those numbers,
Yes.
if we took the block and tackle fails, right? So we're talking about just the things that the practices, if they would have cleaned up on their own, that would be what? Timely filing,
Authorization,
authorizations, and
medical, all
Copay,
four of those.
coinsurance,
Yeah, collections
deductible.
from the patients. Those items, medical necessity, that one you could probably take out of there, the $4.8 million. That
Yeah.
is hit or miss what the practice could have done
Right.
differently on that. But yes, definitely taking away $4 million of that would just leave that right around $49 million.
Yeah. So that, I mean, that was, and that, that is one of those things that is difficult, I think, as we look through all this stuff to communicate with the practices. You know, I get it's frustrating that you've got so many hurdles and administrivia bumps to actually get paid. But on the flip side, whether or not you're contracting with a payer is a choice. I mean, you may not feel like a choice, but that in the end, it is a choice. And signing that contract obligates you to follow those rules. And the prior authorizations and the patient collections, and I mean, all those things, that timely filing issues that are there, I mean, those are tough, and things that we see across the board. Um,
Yeah.
Demographics being another one that's out there, which of course we've talked about many times, which is again data entry,
Yeah.
communication, block and tackle errors. But anyway, I just wanted to reiterate that a lot of that was self-inflicted. Um, we all complain about the payers and what's going on, and they definitely have their fair contribution in this, but a lot of this could be fixed by the practices.
Correct. And I was even asked this week, um, what is the acceptable timely filing that you should have in your practice? In my opinion, I mean, we've talked about this a lot, Mark. It's none. I mean, you shouldn't have timely filing. This is not anything, and us as an outside vendor, a lot of times for billing, that is not something that's acceptable. That means you're not following up on your claims. And so when I'm saying that $21 million is an item where just following up on your claims and your denials would prevent that in the timely fashion, and doing that every 30 days would prevent that alone.
And during the conference, the reaction was um, full-throated, let's just say, for several people in the practice, with frustration on all sides.
Yes.
Um, and and quite for the other piece was it really spanned the gamut of practice size from small to large,
Correct.
across the board. Now, I would say the smaller practices, um, interestingly, were not as big in that participation. I mean, a lot of the smaller practices, your physicians are a little bit more involved. Um, and maybe that's why this is something that's grown exponentially
Mhm.
over the past few years, as in bigger groups, you're further and further away from being able to affect change or participate and actually monitor what's going on. And I think that was one of our frustrations we saw as well, is people not being able to get access to the data in a
Yes.
timely or manner or a format they could actually live with.
Yes, and that was actually one of the providers brought up, is that they actually had been requesting data and it wasn't being delivered to him in a format that he could work with or understand, and had to ask multiple times for different data. So I see that often, and then understanding what you should ask for. And so you're just asking, can I have reports? And they deliver you something, but it's not something that actually is a workable item to let you see through your data, and how your claims are being processed, and what's left on your aging, which is your aged accounts after it's been processed, the insurance that hasn't been paid by the payer yet, and seeing that data.
So true.
I just want to kind of give an overall view. First of all, the attendees range from urologists, APPs to coding billing staff, managers, and also there are a couple of people from industry who attended the course. It seems like every single year there's always a few people from industry, whether that is folks who do auditing or people who work in the urology product service delivery space, attending these meetings. And the some of the comments during the meeting, you can feel the frustration from the urologists, and the fact that they didn't know about the information that we were talking about, and now after hearing the information, how frustrated they felt not knowing the information beforehand. And I would feel like, oh my gosh, I've been screwed for so long and I didn't even know how much money I was losing. And what Marianne is talking about with the $53 million write-off, that's lost, that's gone. A lot of that is preventable. A lot of it, as Mark said, block and tackle, stuff that the urology practice can and should do. Timely filing, not meeting the timely filing requirements for the insurance companies, by the insurance companies, and then writing that off, that should be a never event. Just like operating on the wrong site, that should be a never event.
Yeah.
And yet, that is not what you're seeing, Marianne, which is
No,
just,
correct.
it's like facepalm when you see that. Why would you not do that? And just like getting the correct demographic information, like you said, a lot of that blame should be shouldered by the urology practice. But unfortunately, we're so busy, we just want to keep seeing patients, and we hope and pray. And I hate to say this, hope and pray in today's medical practice is not a way to stay viable.
No.
You can't hope and pray. You have to be proactive.
I wanted to, if you, really quickly, also on a conversation from that conference, timely filing is not just getting your claims, you as a provider or you as your practice, having those claims be billed to the insurance after you see the patient in a timely fashion. For example, a payer might have a 90-day filing to get your claim in. That also, there are timely filing requirements on the back side of all of the aging. So if a payer denies a claim, many of the payers have timely filing requirements for how long you have to do a redetermination or a corrected claim. So if you get a denied claim and it sits in there for 180 days and then you have the staff to go ahead and work those accounts, many of those claims with many payers nowadays, you are already out of timely filing for even appealing or doing a corrected claim on those payers. So there was a misunderstanding from some of the providers saying, my staff is letting me know we're getting all our claims out. We only have a 2-day lag on getting charges out to the payers after we complete the charges. And as providers are getting the charges signed off in 48 hours, those are going out. So I know we're meeting timely filing. There is a timely filing requirement on the back end. And also, once you do appeal a claim for some payers, you also have to have every 45 days on some payers, you have to make sure you are having action on that account to keep that claim live in that system. Otherwise, again, if you appealed and you never followed up on that claim for another 8 months, you also are out of timely filing with them.
Yeah, so there's that initial filing, and also
Yep.
if the claim is rejected, you have to work that in a timely fashion as well.
Yes.
And
Yes.
I just talked to my biller yesterday. We had one claim from August of last year. We submitted the claim, but then the insurance rejected the claim. It was a rejection code that she was familiar with, so she applied whatever the usual Band-Aid is to get that, and she resubmitted it, and that was rejected because of that secondary timely filing that did not work out. So we ended up having to write that off.
Yeah. And so I just wanted to make sure that providers understand that if you're being told timely filing is not a problem, also look on the back end, because that could be an issue as well. And that's where we're actually seeing a significant amount of this happening on the backside because of a lot of staffing or just not having knowledge of how to actually properly appeal a claim.
It's always interesting to me when we're at the seminar and you're talking timely filing, that's one piece of, as Ray Painter always coined, the wheel of fortune. And that's from when the patient first contacts you until that money gets in the bank. There are a lot of things that need to go right for that to happen. Most things, a lot of the providers, a lot of the urologists and APPs, billers, coders are another thing. They don't know what they don't know.
Mm-hmm.
And that's just such a cliche saying, but it's really true. And we saw that happening when the attendees at the seminar suddenly realized that they had no idea that that particular part of the Wheel of Fortune was what they were missing, whether it be timely filing, pre-certs, pre-auths. They may know about it, but they don't know the intricacies and they hadn't been paying attention. So a lot has to go right to make sure that you capture the reimbursement for all the services that you're providing to all the patients. And there's just so many moving parts, and it does take that knowledge to be able to ask the right questions to get the right reimbursement.
And some of the most interesting conversations obviously occur typically not during the meeting, but it's the sidebars. I don't know about you, Marianne or Mark or Scott. They come up to you, the attendees come up to you and share information. So one of the conversations that I had was I had a discussion with a group of folks from practices near the South. We'll just leave it anonymous. And she shared that the top line revenue from a urology, their practice. And I said, okay, well, I'll share my information as well. They told me the volume of patients that they were seeing. They were seeing twice as many patients as I was seeing and making half of what I was making. I was seeing half of the number of patients that they were seeing and then generating the same amount of revenue. So understanding the rules allow you to practice easier, happier, and more efficiently. And a lot of people ask me, oh, how many patients do you see a day? It almost, yes, it matters somewhat, but the revenue per patient per visit, that is something that you really need to understand as well. So there's just the wheel, and I will go even further when it comes to the wheel of fortune. Wheel of fortune starts from the time the patient contacts you until you get to keep the money. Keep the money.
Very, very true.
It's
Correct.
Very true.
Yeah, it's not just the money hitting the
Yes.
bank, but then the recoupments, the takebacks.
That's a
Yes.
good point. Very good point.
I mean, a great point actually, because just because you got the claim paid doesn't mean it was actually the right thing, and the recoupments are on the rise. I mean, and also because again, recoupments aren't being attended to and reviewed to see possibly many times those need to be appealed because the payer was incorrect, and we've seen that as well. So if they are paying you and then taking it back and you're not understanding your full revenue cycle at that point anyway, and you do not tend to those, they just get posted to the accounts, you may also had additional loss because they actually paid you thought everything was good, and then they came back and recouped it. And those things sometimes get lost in some practice management systems in a bucket of credits or items that may not be looked at, and that is also another loss. And we are seeing that there are some payers that will pay the claim, send you a letter requesting medical records, and if those are not sent to the payer, they will recoup the full payment.
And not only just the medical records, the right medical records.
Right, yes.
And this was one of the most impassioned rants, if you will, from one of the physicians, urologists at the meeting this past weekend, how he went from switching, he went from work RVUs, getting paid by his work RVUs, to collections, and how when he dug into it, how he was not being paid for a PCNL that he was doing, and then the subsequent uroscopy. Everyone had a good laugh when he finally ranted, and then he said, well, here's my question.
He called it therapy.
in some way.
And in that fact, he did justify the fact that he thought the payer did ask for records, but then he did find out after calling himself to the payer that the incorrect records were sent, and that delayed the claim even further. And when we're talking about, hey, you need to make sure that if you have a request for urodynamics and your staff sends the records from the provider, just the visit, and doesn't include your urodynamic results, those results can result in a take back, and you get the records don't support the codes billed, and then you get the recoupments, and you say, but I sent the records, and you send the same records again and again and again. Those things are just making sure the education on not only the providers then, but your staff. Is your staff educated enough to review and work these claims on your behalf to get these paid? It is a big part of what's happening right now. A lot of people are being placed into positions and they don't have the background or the understanding, and they don't have an outlet to ask the questions, and therefore they're making it up as they go, fake it so you make it kind of stuff, and is resulting in some very costly errors.
Yeah. I know we're going a little bit long on our event today, so we may have to reconvene and talk about some of the other portions of the Wheel of Fortune that we covered during a great seminar. I mean, a lot of participation, a lot of conversations, and we covered a lot of ground. But I will say, sticking in this vein, we kind of started here because each day we ended up starting off the conference talking about different aspects of the pre-visit and then the AR, so the follow-up. So those were kind of the money topics, and on the administrative side was the very beginning of each day, which kind of took us on those deep dives. But one of the things that I'm going to add in the mix, every practice that we are seeing around the country right now, well, I don't say every practice, the majority of practices are suffering from turnover. Um,
Hmm.
and, that staff that was there for a long time, or that staff not being able to stay, makes it so much more important for you to have written job
Yes.
descriptions, roles, responsibilities, and accountability. Um, and subsequent training and support. Um, those are things that are significantly contributing to these fails. Um, so, I kind of walked away from all of this thinking that, maybe not only having the ability to, and we're going to try and get some information together on what are the best reports to monitor for your practice. Um, but the other part is, being able to actually deal with the realities of your practice, with turnover, having good training, having good support, and having those roles and responsibilities outlined so that you can actually monitor that everyone is doing the job that you ask them to do. So I think that's one of those pieces of the puzzle that I put in the block and tackle category, um, that people are missing, and it's costing plenty of money. And Marianne said the other day when we were looking at all of these numbers, yeah, if we could actually, from a physician side, from a physician practice side, actually take care of all of the responsibilities that we have, um, we wouldn't see incomes going down at this point. Um, there is so much bleeding from a financial standpoint in every practice that we run up against, that is in your power to correct, and that needs to be a focus, I think, of every practice to get the business financial support for the clinical care that you provide.
And we deal with that on a daily basis with, I mean, on a daily basis with turnover and just unfortunately tragedies that happen with your staff, whether that be with their family and they don't end up coming back to work, or they need to be out away from work and they're in a position of your practice that is important, and you guys don't have what they have been doing outlined, and therefore it gets, you guys fill in the holes, we fill in the holes, but we don't do it correctly, and then we find out 6 months later that one of those pieces that that person did wasn't being done for that 6 months, and that also contributes to that loss. And those workflows are extremely important. As you have training, if somebody doesn't come back the next day, then the person who didn't do that job is now training that next person, and things are going to get lost, and that happens often. I mean, we're talking to people, I didn't know I was supposed to do that. So it's very important to have those metrics in place. And I just want to, one thing, I currently have a $75 copay for a specialist. If I go and see a urologist and I don't pay them that $75 and I get seen for a 99213, you as a provider are going to be paid, whatever, $25 to $26, and that $75 then gets billed to me. And if I don't, you get costs for statements, you get costs for your staff to call, you have, overhead that you have in your PM system. So that contributes to the loss as well, because when you're not collecting what you know has to be due at the time of service and collect the proper, there's a difference between a lot of plans have a different PCP versus specialty copay. If it's a $50 copay and you collect the PCP one, you only do the $25, then you're still billing that patient for the $25 and at a loss. So those things that you know you can do right at the time of service and that the patients expect to have, they know they have to pay that. If you're not collecting that, that is contributing to the loss.
That's so true.
Preventative moves.
Yeah.
Yes. the final thing I'll mention about the seminar, and then we'll go around and get some final thoughts on the episode. But we did, and this may spark some discussion, but we did also hear from one of the docs that talked about, we talked about the rules of the game. So we're in the game, how to follow those rules and make sure you get paid correctly and accurately, reimbursed accurately. But there's another part of this, and that's actually trying to change the rules of the game on a bigger picture. And physicians in general have been, and I think the quote was, or I think the amounts, and I don't know if I have the amounts specifically, maybe you guys can remember, but the hospital lobbying group has, hundreds of millions of dollars, whereas the physicians lobbying group has maybe $100,000, at
Yes.
least the
It was
It was
urology group,
110 or something like that. Yeah.
$110,000
Yeah.
that they've raised, and they were happy that they raised that much. And you can't change the rules of the game without playing that game of changing the rules, and that's a Washington game in the Congress and really lobbying. And physicians haven't done a great job, and you can see that in the payment drops that happen to the physicians as a when you compare that to the hospitals, that they are getting increases, the ASCs are getting increases, but the physician payment is going down. So that there has to be some more organized, and this doc said you should contribute to the urology pack. So, that's one of the big, outside of the rules of the game to getting paid, trying to change the rules.
Yeah, going on offense instead of always being on the defense, contributing to the political action committees or the PACs is definitely important. AACU, I think, is one of them, and then urology also. AUA also has a PAC. Physicians are in general very not very good in contributing to these causes, as opposed to the lawyers and also the folks in the American Hospital Association. They are big contributors to their PACs, and so they have influence at the table in our messy democracy.
Yes.
Yeah,
All right.
we didn't design the rules of the game, but we got to play by them. So
Yeah.
that's one of the rules.
Yeah.
If you play by the rules too, you have a lot more leverage on the backside when you're fighting. When you one of those pieces are not done correctly, then it's a lot harder to recover the income.
Yeah.
If at all.
All right. All right. Let's wrap this episode up here. We're going to go around, and we'll give the last word to John today. But let's get some final thoughts. Mark, final thoughts.
Yeah. So I guess in the end, it's always one of the advantages of popping around the country or dealing with our national conferences is we get to talk to people in different parts of the world and their different aspects. I mean, healthcare is national, but in the end, it is still very local and geographic. Those influences and your decisions with your patients, those are all local, and they make a difference across the board. And ultimately, what we try and do is share all that information so that somebody finds something that works. We can pass it around to other folks, and hopefully that everybody, actually not hopefully, everybody at the conference, the feedback we got was that this was extremely helpful, and ultimately opened their eyes to some things that they could do to affect positive change within their practices. And that I think is the one of the pieces that everyone should take away. You can't fix every problem right off the bat, but the slow and steady approach of taking things, making sure they're fixed, and moving to the next one, putting those systems in place, and moving forward with measurable pieces so that that it wasn't just, all right, we fixed it, and then 2 weeks later you're back to where you were. Because change is hard. It does need to be affected over time and followed up on. So I hope that everybody that attended that conference has a couple things that they really did and do continue to provide their practice to support that financial lift.
All right. Marianne, final thoughts.
I just want to encourage everybody to keep asking questions. If something doesn't seem right or you're not getting the right data, keep asking for the data that you need. Dr. Painter always trust but verify. Make sure that if you're being told something, it doesn't seem right, get the data behind it. And there's nothing wrong with asking a couple of the questions. You don't need to know everything regarding revenue cycle, but understand and know that your claims are getting paid. There's a lot of different metrics that are out there. And like Mark said, we're going to try to get those out to you guys with reports that we would provide. Just keep asking questions because actually the most impactful practice that we have is communication. Where we have the best communication from the start of your front office all the way back through the RCM and providers. That is important, and those are the most successful practices that I work with. Is when that loop is there, and everybody sharing their experiences and their knowledge with each other, so that makes it better for the entire practice.
Agreed. All right, John, final thoughts.
I'll leave everyone with this. The chains of habit are too light to be felt until they're too heavy to be broken. What I mean is status quo bias that is pervasive in medicine and in urology as well. Commonly, I hear this. We do it this way because that's the way we've always done it. I want you to consider challenging that. And one of the ways that you can be enlightened, if you will, is consider joining the Thriving Urology Practice Facebook group. It is free. It is only US-based urology folks in that group. After attending the meeting this past weekend, one of the attendees wrote, and I quote, "I would just like to say that the billing conference in New Orleans was amazing and one of the most formative conferences I have ever been to. Since coming back, I have implemented the following." He listed 4 big items with sub-items in one of the posts. In addition, someone responded in that same post, a 37-item list of things that he learned from the conference that he's going to implement. Now, unless you don't know where to start, you don't know what you're missing, consider getting yourself educated. As urologists, we think we know a lot. We sometimes think we know it all. But unfortunately, when it comes to coding, billing, it's a big, big game with a lot of nuanced rules. And those of us who know the rules better, playing it with a lot more fun, if you will, even though some people may think, well, how is it fun dealing with insurance companies? But I digress. Knowing the rules and play within the rules, if you want to continue in the third-party paying game, it's going to make you a lot happier. And the meetings are just one way to do so. And I'll give a plug to something that Ray, Scott, and Mark are putting together. It's the Urology, Pharma, and Tech Pioneers monthly meeting. And maybe, Scott, you can put that in the show notes. It's a monthly meeting where people get together, people in urology get together and trying to figure out how to implement and also get paid for the newer technologies that are coming out. But always be willing to change, always be willing to hear new ideas and consider implementing them. Because education without execution is just entertainment. Back to you, Scott.
Thanks, John. Great points. All right, let's wind this episode up. We want to thank ModMed for supporting this episode. If you're in the market for an EHR or a practice management system, you can go to modmed.com/PRS network for specials for our listening audience. Also, John mentioned the show notes. If you want to, we'll put a link to joining the Urology, Pharma, and Tech Pioneer group. So we'll put that link in the show notes, as well as a link to joining the Thriving Urology Practice Facebook group. And also, if you want to schedule a call with Mark and Marianne and talk more about revenue cycle management, or if for those of you who are not familiar with that term, billing, coding, audits, that link is also available. And that page that you can visit is prsnetwork.com/229 for episode 229. That's all we have today. Thank you all very much for listening. Take us out, John.
As always, thank you so much for the privilege of your time. Please take care of yourself and each other. Happy coding.